皆様こんにちは。今日は SVR についてお話ししたいと思います。それは何ですか？最高だ。聞いてくれてください。はいや。Alright, we're now going to take a look at systemic vascular resistance. What is that and what do we need to know about it for the purpose of the exam, but also even in real life? Well, first we have to take a look at the heart. The heart has the envious task of pushing blood by contracting through all of the tiny little vessels that go through the body. Well, as you might imagine, pushing any liquid through any little tube like a blood vessel takes a little bit of work. It takes a little bit of force. That force we can measure and we can call that vascular resistance. We can actually put a number on it. Systemic just means that's the amount of force that it takes to push through the vessels of the body compared to pulmonary vascular resistance, which is the amount of force that it takes to push through the vessels that are related to the lungs. But for now, we're just going to look at the systemic side of things, the amount of pressure or force that it takes to push blood through all of the little tiny vessels into the distal parts of your body. That's called the systemic vascular system. Now, as we take a look at what force it takes to push blood through the vessels, the question we might have is what would cause the systemic vascular resistance or the force required to push the blood through the vessels to increase or decrease? And, well, why do we care? Well, the best way to look at this is to imagine a straw. And so you can imagine that if you have this little cup of coffee and a tiny little coffee straw, which really is not really made for sucking the coffee through, it's really made for mixing it, but still, it is a straw. Well, you can imagine if you tried to suck your coffee through that little straw, it would be kind of difficult. And that's because that straw is very, very narrow. The same thing is true of our blood vessels. They can constrict, they can become narrow, they can become hardened from disease, and the more narrow they are, the more force it takes to get blood through them, and therefore the vascular resistance would increase. But now imagine a larger straw. This is really a boba straw you've seen in some restaurants. It's gigantic, it's huge. It would be easy to suck up a soda through this thing. Wouldn't require very much force at all. In other words, it has lower vascular resistance or lower resistance to get the fluid through a straw. The other thing we can think about, it just depends on what's going through the straw. In our case, it's going to be blood going through all our vessels, but not all blood is equal. In other words, we can have blood that's been thinned and easy, like a thin soda. It'd be easy to push that through our vessel straws, right? But what if our blood was thickened? What if we have lots of hemoglobin? That would be kind of like trying to suck up a milkshake through a straw. As you might imagine, if you use a tiny straw and the milkshake is very thick, you're never going to get the milkshake into your mouth. But if you use a big straw and the milkshake, even if it's thick, you can probably still get it through. And so these are some of the components that cause vascular resistance to increase and decrease. As it relates to the heart, we might also add that if the heart tries to pump a lot more, push a lot of blood, the heart rate is up, then it's going to be pushing a lot of blood. It's going to take a lot more force gradually and generally, and so that would also increase vascular resistance. So let's take a closer peek at how to calculate systemic vascular resistance. But before we talk about the number, let's keep in mind about the implication here. Whenever the systemic vascular resistance is high, we're saying that the heart has to exert more force or more contraction power to push the blood through it. We do care about that because if it's constantly high, if it's constantly difficult for the heart to do that, then it's going to work hard every day, every beat, and it's consistently going to have to work hard. That's going to cause a couple of problems. One, it's going to cause the heart muscle to become bigger. Now, like all of the other muscles in your body, if they become bigger, we think that's good. We don't necessarily want our heart muscle to become super big. We call that hypertrophy, and that can be bad. It's more difficult to maintain that kind of heart. If somebody is obese, then they have their vessels that they have to push through. They may have high blood pressure. That's going to increase the systemic vascular resistance. Ultimately, that heart has to work a lot harder, and therefore the heart could wear out just a little bit faster or stop or wear out prematurely. So we do care about high systemic vascular resistance. Certainly you need a little resistance in your blood pressure and in your vessels, but we like to keep that number low. Now we're ready that we understand that we can calculate the number associated with systemic vascular resistance. Now, as we take a look at the number or the value associated with systemic vascular resistance, which I'm now just going to call SVR, it's really quite simple. And of course, if you're working in an intensive care unit, then probably you can just look at the SVR value. It's probably up on the monitor already. It is considered one of the hemodynamic hemodynamic values that are typically reported. But if you're on the NBRC exam or you're just a nerd and you want to know how is this really calculated, then that's what we need to talk about. SVR certainly can be seen on the exam. It can be seen on the TMC exam, the brand new exam that will come in 2027, the respiratory therapy examination, but it's also on things like the ACCS, the Adult Critical Care Exam, so you really do need to know this for the NBRC. All right, at its basic form, all we're really looking at is the blood pressure required to push blood through the vessels. And that means we can say that if somebody has higher blood pressure, they are definitely encountering a higher systemic vascular resistance. But let's calculate that and take a look at the value a little bit more closely. The first thing we need to do is take a look at blood pressures, and we kind of have to stop our topic on SVR just for a moment to talk about how we look at blood pressures from a different perspective hemodynamically. Now, you're familiar with blood pressure. If I said what's somebody's blood pressure, normal blood pressure, you're going to tell me something like 120/80. This is where we have to stop for just a moment and talk about blood pressure from a different perspective, because when we speak about hemodynamic terms, including SVR and PVR, pulmonary vascular resistance, we're going to be speaking about an average blood pressure. So we stop generally talking about SVR or blood pressure from the point of view of something over something, a systolic over a diastolic. So we're not going to talk about 120/80. We're going to take the average of those pressures. Now, you might think if I was averaging 120 plus 80 divided by 2, I'd get some kind of average there, but we can't quite do that. We have to introduce a new concept to you called calculating the mean arterial pressure. This is the same thing as blood pressure, but it is calculated from an average point of view. The difference is we can't add the 120 plus the 80 and divide by 2 to get the average pressure in between those two things. That's because we spend twice as much time in diastole. And so we spend 1 part in systole and 2 parts in diastole. Because of that, as we look at MAP, the formula is going to be 1 times the systolic pressure, the 120, plus 2 times the diastolic pressure, which is 80 if you're normal. So 80 plus 80, 120 plus 80 plus 80, and then we have to divide that all by 3. As you divide that by 3, that's going to give you the blood pressure. And in this case, if I divide all that by 3, what do I get? I get about 93, 93.3, something like that. And so if I'm in the ICU and I ask you for what's their blood pressure, and you tell me it's 93, I may say 93 over what? And you're going to say, no, I didn't tell you the systolic over the diastolic. I told you the mean arterial pressure. And so blood pressure of 93 is going to be the same expression as 120/80. You do need to be able to calculate MAP, so remember that for the purpose of the exam. Sometimes they ask you just to calculate that. But we need to use that blood pressure when we calculate SVR. Okay, with that in mind, now we're really ready to calculate SVR. Let's do it. Now, remember I said that calculating SVR is really just about looking at blood pressures. Kinda. You could kind of just look at a blood pressure, in this case 120/80, which we've now converted to the MAP, and say it's about 93. And I could say it takes about 93 millimeters of mercury to push the blood through. That's the blood pressure required. Kinda. There's kind of a trick here. What we really want to look at when we look at SVR is how much pressure we had at the start and then how much pressure we had at the end. Now, this is going to get a little bit hemodynamically nerdy for a minute. As the blood comes out of the left heart, it's coming out at 120/80, which we agreed now is 93. We're going to look at it as the average pressure and not the systolic over the diastolic, 93. And then it pushes it through all the vessels in our body and it comes back up. It ends its journey at the right heart. From there, it's going to start to go to the pulmonary system. We're not focusing on that right now. The question is, what's the pressure at the end of as it enters the right heart? That's the ending pressure. And that would be called central venous pressure, or CVP. You've probably heard of that before. And so let's just say CVP is 3. Really, it's 2 to 6 torr as a normal, but we're just going to make it 3. That means if I started off with 93, then the pressure it took is 93 minus the ending pressure, which is 3, so the difference is about 90, and that is the vascular resistance. Well, kinda. We have to put it in a different unit, but that is the amount of pressure that it takes to push the blood through the systemic side. It takes about 90. Now, SVR is in a different unit of measure, so we have to kind of change that, and we will do that. So there is a little bit more to the formula, but that's at the heart of it, just the difference in the starting pressure minus the ending pressure. That's the amount of pressure it takes to push the blood through all those vessels. That's the calculation for the vascular resistance. Just to drive this home a little bit, this idea that we have to have a starting pressure and then what's the ending pressure, we subtract the two to figure out what the difference is, and that's the amount of force. It's very similar that if I sent you to the store to buy, let's say, a watermelon, and I gave you $10 and you came back with a watermelon and I said, how much that watermelon cost? And you said, I don't know, I don't remember. What I could do is say, well, how much money do you have left? So if I sit you with 10 and you pull out $3 in your pocket, then I can deduce that the amount of money that that watermelon cost is $7 because the starting money was 10, the ending money was 3, 10 minus 3 is 7. That's how much the watermelon costs. Same with systemic vascular resistance. The starting pressure was 93. The ending pressure was 3. How much did it cost? What's the pressure that it cost to push the blood through there? Well, it's the 93 minus the 3. Now, to finish the SVR calculation, there's a couple of other things that we have to involve. First of all, we know that the first part of the formula is MAP minus the CVP. That's the starting pressure minus the ending pressure. But to be fair, each of us, to compare that value between people, we also have to consider, well, how much volume went through that, and that's called cardiac output. So the next thing we're going to do is we're going to divide by cardiac output, and that would make all of our values equal to each other. So I could say this person's SVR is this, and your SVR is this, and we could compare. We would understand relatively that those are about the same thing. So to be fair among different patients, I have to divide by the amount of blood that went through there, and that is the cardiac output. Now, I would be finished there, except we have to do one more thing, and you're going to love this. I hate this. And we have to convert it to the Swedish unit of force. I don't know why. There's lots of American units of forces that we could use. Heck, blood pressure is a unit of force. But we're going to use the Swedish unit of force called dynes, D-Y-N-E-S. And it's also got some other exponents to it, and you can look at that. But to get it in the unit of dynes, all we have to do is take our number, MAP minus the CVP divided by the cardiac output, whatever number we get there, and times it by 80. I know, that's just a number you're going to have to memorize. But timesing it by 80 gets it in the Swedish unit of dynes, and that will become SVR. All right, well, let's do a practice problem. So let's just take a peek. Let's pretend like we have somebody who has a blood pressure of 120 over 80. In order to get that into the MAP formula, we have to go 120 plus 80 plus 80. Remember, 2 times the diastolic divided by 3, and we're going to get a blood pressure of 93, about 93.3. We're going to drop the 0.3 right now. So 93. And then we have in this patient, we see that their cardiac output is 5 liters a minute. So we're going to take the 90 and divide it by 5, and we get 18. And we're very close now. We just have to take that 18 and times it by 80 to get it in the Swedish units of dynes. And when we do, we get 1440. So this patient's SVR is 1440 dynes. All right, just to add a little bit of context of what's high and low here, and you can memorize this. It's not super important, but if it's below 700 dynes, then that's considered low. You have some kind of very low resistance. You probably have a failing heart, and your blood pressure is also remarkably low as well. We don't often care about low dynes or low pressure. We don't look at that. There's probably something more significant going on at that point, so we can just look at the blood pressure and see the patient's in trouble. We're not going to take the time to calculate a low SVR if we care about that. But we do care about it if it's high. And anytime the SVR goes over about 1500, that's whenever we consider that high. And we're going to want to look at something closely. Why is that happening? Is it because the vessels are contracting and they're narrow? Is it because the blood is thick? Is it because the heart's trying to just push too much blood? The heart rate's too high? There could be any number of reasons that increase SVR, but we need to address that. But first, we'll understand that that's a high SVR. All right, now let's take a look at another patient. On this patient, we have a MAP of 110. They may give you the actual blood pressure and you got to do the MAP formula, but after we do that, let's say we got 110. And then we look at CVP, and CVP, that's where the blood ends, and the systemic side, it's 10. So the first thing we need to do is we need to take the 110 and minus the 10, and now we have 100. To be fair among patients, so we can compare relatively among patients, we now have to divide it by the cardiac output. In this case, the cardiac output, we just left it at 5, so 100 divided by 5 is going to be 20. Now all we have to do is times that by the Swedish unit conversion factor, which is 80. So 20 times 80 is 1600 dynes, and that would be the SVR in this case. All right, we can't resist but doing just one more. So take a look at this patient here. First thing you'll notice is that they did not give you the MAP. They did give you this blood pressure in terms of a systolic over diastolic. In this case, 170 over 110, and you're going to have to calculate the MAP. Remember, to do that, we're going to take 1 times the systolic plus 2 times the diastolic and divide by 3. In this case, we're just simply going to take 170 plus 110 plus 110 twice, right? Divided by 3, we get 390 divided by 3, and that's 130. So that is our starting pressure. That's our MAP, 130. Now all we have to do is subtract the ending pressure, which is CVP, and so 130 minus the CVP of 10 is 120. We could stop there, except now that we have to think about every patient to make them equal, so we want to divide by that patient's cardiac output. In this case, the cardiac output is 3. And so we're going to take 120 divided by 3, and now we get 40. All we have to do now is to put it in the Swedish unit of dynes. So we're going to take that 40 and we're going to times it by 80 and we're going to get 3,200. And so SVR in this case is 3,200. Remember, we considered 1,500 or higher, very high. This patient is very, very high. It's taking a lot of pressure to put a very small amount of blood through the vessels. Therefore, they have a very, very high SVR. And that's how it's calculated. Remember that you need to know this for the purpose of the NBRC exam. And of course, if you're a bit of a respiratory nerd and you just want to know how it's calculated, that's how it's done. On the NBRC exam, they could ask you, for instance, though, what would happen if cardiac output increased? And you may want to get your little pencil out, paper out, and say, well, what happens if cardiac input increased? What would happen to SVR? Would that cause it to increase or decrease? So the NBRC has historically liked to ask you in a formula, not the formula itself. Sometimes they do. They may have you calculate that, but they may just ask you, what impact would a change in one of the values have on the SVR? I never know just by looking at that, unless I do it a million times. So I get my pencil out and I calculate a couple of SVRs by changing the value that they want me to change. Typically, it might be cardiac output. What if cardiac output were higher? What would happen to SVR? That would make SVR go down. You can do the calculation and practice that, but that's SVR. That's how you calculate it. You do need to know that for the purpose of the NBRC exam. And if you're a nerd, it's also helpful just to know in real life, though in real life, the value is probably just reported on the monitor.